Hello and welcome back to the scientific sessions of MiECC's anniversary meeting. We are about to start the Ask the Expert sessions as we doing to all the symposia of this society. So we have recruited a number of key opinion leaders in the field, trying to integrate the multidisciplinary approach to what we are advocating all these years. So we have surgeons, anesthesiologists, perfusionists in this MiECC technical considerations session, and I will present all of them beforehand, and also I will present the questions that we will ask them. To make it short, I will ask each of these participants to answer any of these questions that they would like once, all of them, and if we have time at the end, we might accept questions and do some comments. So I will present the discussants, and then Professor Antonitsis will present all the questions, and then we will start the way that I will announce the names. First is Ashraf El-Essawi, who is a steering committee member, and he is currently in Göttingen. Ignacio Condello next to me. Ashraf is a surgeon. Ignacio Condello from Bari. He's a perfusionist. Hans-Jörg Jenni. He's a perfusionist also from the Bern. Brian Beairsto from Toronto. He's a perfusionist. Helena Argiriadou, she's an anesthesiologist from Thessaloniki, my team. Naomi Kimura, he's a surgeon from Saitama, Japan. Sten Ellam, he's an anesthesiologist from Kuopio. Yusuf El-Dsouki, he is not here, so we will take him out. And Christophe Baufreton, he is a surgeon from Angers. All of them good friends, all of them key opinion leaders in the topic, and I hope we will have a fruitful session with their help answering which questions, Polychronis?
So we'll start with the. So we'll have a set of questions that you can see them on the slide. The first question is current evidence sufficient to justify adoption in clinical practice to MiECC? Why do you think there is no wide acceptance of it? Are modular systems necessity, or should we prompt to MiECC in CABG and AVR cases while using optimized circuits in the rest? 3, about venting. Is venting in MiECC a demanding issue? Which are the options? Nice field. Do you think that use of MiECC may allow lower than traditional cardiac index without end organ damage? How do you deal with cardioplegia when using a MiECC circuit? Are low ACT protocols widely applied in surgery on MiECC? How low can we go? Are fast-track algorithms in NERACs enhanced with MiECC use? Do you think MiECC is mandatory in NERACs? Are patient blood management protocols enhanced with MiECC use? Do you think MiECC is mandatory when opting for patient blood management in cardiac surgery? Is the rationale of MICS, minimally invasive cardiac surgery, valid without MiECC use? What are the difficulties when applying MiECC in MICS? Do we have to redesign components of MiECC circuits? Which will be the major recommendation to the industry for simplifying MiECC strategy? And last one, which is the main issue for not adopting MiECC in its discipline, surgery, anesthesia, perfusion? Which could be the actions, respectively, for making MiECC use appealing? So these are the questions.
So there are 11 questions, and we have 8 discussants. You can take any of these questions that you would like to answer. Please be brief, so we will have another round with comments regarding what will appear from your answers. So Ashraf.
Second question. Are modular systems necessary? And should we opt for optimized extracorporeal circulation for more complex cases? And one of the main differences between minimal invasive surgery and minimal invasive extracorporeal surfaces that minimal invasive extracorporeal circuits target physiology. We're trying to respect and maintain homeostasis, thereby preserving physiologic reserves, aiming at what we would call an optimum outcome. If we're speaking in Eros language, we would be speaking about enhanced recovery, but actually we're all dealing with reaching an optimal outcome. The advantage of respecting physiology is that the trauma that the heart-lung machine is inflicting is increasing as the longer the duration of my operation. And as such, the longer the duration of the operation, the more complex the operation, the more the benefit or the difference will be to a conventional system. Opting just for cabbage is the wrong way. This is a mistake that the pioneers of MiECC had done in the beginning of MiECC. They introduced MiECC with the idea of using it as an assisted beating heart system or an alternative to OPCAP, and resulting in that one of the largest meta-analysis to date, with over 50,000 patients, I think, from Kovalevsky et al., they showed that in each and every aspect, MiECC was superior to OPCAP. But in their conclusion, in the conclusion of their paper, the whole paper was, they analyzed that MiECC was superior to OPCAP. But the conclusion was, MiECC could be a good alternative to OPCAP. And this is definitely the wrong way that we shouldn't go. The more you definitely should start your MiECC practice with simple surgeries, but your target has to be a modular system. Your target has to be a type 4 system. The classification was good for sorting out the publications, giving us possibilities to compare different results, but we definitely have to endorse modular systems that can be universally applicable for all types of surgeries. I think I spoke enough.
Any other question to answer?
So I will ask Ignacio Condello. Ignacio Condello is a chief clinical perfusionist in Bari and I believe other hospitals in Italy, and a very, very active and modern perfusionist, to comment on the questions. I would suggest the perfusion issue, like the third one, is venting and demanding issue. Which are the options? What do you think, Ignacio?
I think that this question is really important because today the principal limitation in the use of minimally invasive extraocular circulation is about the use of venting, in particular in the use of mixed minimally invasive cardiac surgery, such as mitral valve repair. I believe in MiECC in the context of minimally invasive cardiac surgery, and the product that we use today, in particular the vent, increase the generation and delivery of gaseous macroembolic activity. I believe that the company, in particular the biomedical company, developed system that improve the management of the venting, because the venting is important to eliminate the gaseous from the heart chamber to protect from cerebrovascular disorders the patients. Is important for goal direct perfusion for the relationship between oxygen delivery and VO2 production, because often with the suckers we have a suction of carbon dioxide. And I believe that it is crucial, the development of a system. Tomorrow I share with the audience our technique and proposal to improve the venting suction during a minimally invasive mitral valve repair. Thank you for the question.
Any other question to answer? Okay, we will go on and see if some questions, because all of them will be answered at the end. So let's go to, we have two more perfusionists. Hans-Jörg, your turn. I think there is cardioplegia here. You have to answer that because you're the expert. The cardioplegia one, you have it in front of you. These are the questions.
That can go with the cardioplegia. I think that the principles of MiECC was also to be volume constant. The online. Okay, sorry. Volume constancy was always important, and be careful to not overload the patient. So I think low volume cardioplegia are really necessary, of course. If it's Calafiore, or if it's a kind of, as we had with the Cardioplexol, it will not make the difference. Important is that it is a low volume Regia. And what we saw, and unfortunately we never found an answer for that, was why it's sufficient to insufflate once 100 milliliters into a heart, and then you have for 45 minutes and a rest. And we also checked, of course, all these parameters, and we could say that we had a protection from the heart, and we never knew if it's really because during mini bypass, because that is also a thing to discuss. The heart is always a bit, you have always flow on the coronaries. We saw that often. Is this flow protective or not? So for that, we never did research enough, but it was something we observed all the time. We had flow. It's disturbing for the surgeon if you have flow on the coronaries, but if this flow is also protective for the heart. That was a question that will never be answered for the moment. Yeah.
Okay, thank you.
Thank you. So we can move to the next discussant. And the next question is Apostolos Deliopoulos, not with us. Beairsto came from Toronto in Canada, and I would like to address him mainly the question about patient blood management. I know that you've done, he actually announced an abstract with platelet preservation. We're dealing with it as well. So what do you think, Brian, about patient blood management during cardiac surgery with minimal invasive extracorporeal circulation? Is it, let's say, an important component when opting for patient blood management in cardiac surgery? You had interesting findings in your study.
Yes, thank you. In terms of patient blood management and using MiECC, at our center, well, thank you. At our center in particular, we only have one surgeon who uses MiECC. And so for him, it's an important process for his patient blood management, especially if he has a small patient coming in that's anemic. We'll really try to target those patients to use MiECC. And we usually cover this at the timeout at the start of the case. You know, what's the blood management strategy? And with him, MiECC is part of that discussion. To make it mandatory at our center, that's not really part of the discussion because we have many surgeons who are not open to using MiECC. So I don't see it becoming a standard at our institution anytime soon, but certainly for the surgeons who do use it, it's a discussion that's had.
Thank you. There are a lot of anesthesiologic issues in this list. I need to reveal, to say that these questions have been made by me and Professor Carrel, who couldn't make it to be here due to an last-minute issue. So we need to pay respect for Thierry that contributed for these questions. So Elena, what about the anesthesiologic questions?
I would like to comment about the ACT protocols. So in our department, we do all case mix on MiECC. So over a decade, we think that a value or a threshold of 300 is completely safe for Gabit's surgery, and for 400 seconds in ACT is completely safe for all other case mix. And we conduct a study with two groups of patients. The one group we titrate heparin only with ACT, and the other group we titrate with ACT and heparin and protamine titration with HMS. And the ratio of heparin to protamine was 1 to 0.7. The main findings of the study is that we are using more protamine than we need and less heparin. So it was very interesting because we did another study and we found that the platelet function was very well preserved in MiECC, and perhaps the less protamine has to deal with it. Anyway, the 300 and the 400 are completely safe thresholds for Gabit's surgery and for all other case mix.
Just have a follow-up question to that, actually.
Yeah.
This is something I was interested in to come here and actually ask you guys is about the ACT protocols.
because we still use greater than 480 for our mini bypass cases, same as conventional. And we'd like to reduce it, but we're not exactly sure where to land. And with our mini bypass circuit design, it's a type 3 with an external cardiotomy. So we have stagnant blood in the external cardiotomy and also in the cardioplegia system, right? You have stagnant blood that's sitting there for 20, 30 minutes. If you use Del Nido, even longer. So I guess follow-up question is, what type of circuit is that? Do you have cardioplegia blood that's sitting stagnant, and just what are your thoughts on that?
We use type 4 in all case mix, and in case that blood collected is more than 1 liter, we don't give the blood unwashed. This is the question that you...
No, what he mentions is if we are using, this is a type 3 also for us, type 4, we are using it. If there is any issue, we have about 2 to 3% conversion rate. So actually, we are operating in a closed system. So if you are using this reservoir blood, you don't have to stagnate. You can recirculate. So don't leave it there. If you recirculate either to the soft shell or to any other place that you're giving it, just recirculate, and it does not stagnate. If you do that, you can go with these heparination protocols that we have. And I can tell you, Adrian Bauer has done also some research on this, and we have done also, we have published. So 300 for cabbage cases, when you do not open the heart, you have no bladder interaction, even from the vents, is completely safe, 300, because this is a tip-to-tip heparinized and also closed circuit. And, you know, we don't have shed blood. As Elena pointed out, we are using some shed blood only if it goes more than 1.2 liters into our reservoir. Then we don't want, to lose the safety marking regarding coagulation issues and also osmotic issues. So because of that, we give it unwashed. Otherwise, we always go through the cell saver, and we don't have that problem. But as I say, 300 to cabbage cases, and when you open the chambers, 400 is more than enough.
I'd like to be a bit provocative on that point, because we have discussed that in the update consensus paper, where Adrian knew the results of Adrian, and we were discussing if we should endorse that in the. And my personal problem is I've used a type 4 system as a universal for all cases, for all comers, and I've done triple valve surgeries with post-operative blood losses of 200 milliliters in 16 hours while using an ACT of more than 480. So my argument would be, why should I shift below 480? What will I expect as a benefit? If I'm losing 200 cc's in 16 post-operative hours, why should I go for less heparin? This has to be an issue, not an issue of non-inferiority. It has to be an issue of superiority, because I'm giving up something that is common practice. I don't know if it's necessary, but at least it's common practice, and everybody has the feeling that they're safe with more than 480. So unless you show me a benefit with superiority, I don't know why should I change my practice.
The advantage is the avoidance of protamine, which affects platelet function.
But at the end of the day, we're speaking about blood losses. We're speaking about coagulation, and if coagulation is fine, I don't think one of the problems that we're having in these discussions is that we cannot reproduce something that you're doing in your center or something that I'm doing in my center, because we have a lot of players involved and we cannot oversee every single step.
Okay, so the question was, how low can we go? It's not mandatory, but what we said, what Helena presented, is it's safe, and keep that in mind. So it is safe to go as low as 300 for epicardiac surgery, and 400 if you open the chambers. I think Christoph wanted to
comment on that point. First of all, I would like to say that I appreciate what you say initially about we have to be more physiologic, and the physiology represents the goal we have to reach. And in my own center, we reduced the anticoagulation since the year 2002. It makes more than 20 years that we do open heart surgery with target ECT at 350 seconds and for cabbages at 250 seconds. And how low can we go? Sincerely, honestly, I don't know. And if you go back to a publication that was done in 2011 with some experts in the field, according to the evidence published in the literature, nobody can answer that question. We don't know. What we know, if you go back to the old literature from 1975, Bull and collaborators, all their papers are always summarized in the guidelines, but what is said between above 300 seconds for a target ACT, the procedure is safe for CPB. But at that time, remember that they were not so well equipped, the equipment was not the same, their computer was not so performant as our mobile phone could be today. They said for extra safety, a margin of safety that could be additional, we consider that an ACT at 480 seconds would be really safe. And from that sentence, all the guidelines consider that you cannot go on CPB below 480 seconds, which is a mistake. We have done more than 3,000 cabbages at 250 seconds. We didn't have any problem. Even sometimes, the lowest ACT during the procedure can go at around 230 seconds. We did not see any problem. The only one time when I see a problem, when I use CO2 for deaering the heart, because CO2, it's not very known, but it's an highly thrombogenic gas. And in the meantime, it will open the highway to the stroke because it will vasodilate the brain arteries. So therefore, be very careful with CO2. There is probably another solution to the other heart than using CO2. But otherwise, how low can we go? I don't know. What I want to do with my database is to check for cabbages with a target ACT at 250 seconds, all the patients with the lowest ACT compared to the patient with the highest ACT, and compare with these two quintiles of patients whether they had different post-operative outcome. But I can tell you, the rate of stroke or TIA was very low, below 1%. And that is similar to what is published. And if you go back to the publication of Room, coming from Scandinavia, a long time ago, with more than 6,000 patients with reduced anticoagulation. It was a low dose heparin, 150 units per kilogram instead of 300 units per kilogram. But the result, the post-operative course, was excellent. It was excellent. So I think that because the purpose of Bull and collaborators were not exactly interpreted as they should be, nowadays we use too much heparin to do the operation. And nowadays we have to think about one thing. The cardiologists insensitive have changed a lot. In my center, more than 50% of the coronary patients used to come under dual antiplatelet therapy. And the cardiologists don't accept that we can stop the dual antiplatelet therapy because the patient had a stent 3 days before the operation, for instance. So he said, ticagrelor is necessary, clopidogrel is necessary for the patient. Do the operation, we cannot postpone the operation for 6 months or 12 months. It's impossible. So we do the operation. And for that reason, considering that ACT is a goal and not the weight of the patient to give the heparin, ACT being sensitive to the platelet dysfunction induced by the drug, then it is useful to consider the target ACT in a reduction of anticoagulation if you don't want to explode the rate of transfusion in your practice. That's my opinion.
Okay, thank you.
I would like to address to Dr. Kimura to welcome him in Thessaloniki. And actually, he's a cardiac surgeon, and I'm inclined, let's say, for the first kind of question. So as long as we're talking about minimization and mobile phones, so I mean, all technologies coming from Japan, everything is minimized. There we have minimal devices and everything in minimal. So why didn't Japan, with a big company in extracorporeal circulation like Terumo, has not adopted minimal invasive cardiac surgery and did not lead clinical practice with minimal invasive cardiac surgery? What do you think? There is no wide acceptance of it, even in Japan, where you have the fastest train in the world, cars without drivers and everything.
Thank you so much. But this seems to be very tough questions.
Yes, yes.
But I think possible the penetration of the minimally invasive ECC is sometimes very difficult because mainly surgeon concerned about the safety issue, I think. So and then so you are asking about the device technology or the pencil?
First device and then adoption of this technology, a wide adoption of this technology.
So some surgeon, some Japanese surgeon are very interested in the minimally invasive ECC, but the number of such surgeons, I think, is very limited. So the reason why the penetration of minimally invasive ECC is slow in my country.
So it needs to start from cardiac surgeons. Okay.
All right. So, Sten, there are unanswered anesthesiology questions for you.
I would like to answer the cardiac index question.
That's good. Yeah, very tough one.
Actually, it's not. So, another way to say that, can we go low? And we can go lower than a normal 2.4 with ease. That is no problem. In our institutions, we run 1.8 to 2 liters. And of course, we do have oxygen consumption and delivery monitoring, very accurate. We use the spectrum devices, and this is the key component. And please bear in mind also the volume assessment of the patient, because the patient acts as your reservoir. So if you assess your volume status incorrectly, you are in trouble. So also you need to take into consideration the surgical handling of the heart and the cannulation, if there is some problem with cannulation, to distinguish these problems from the real hypovolemia. And please use the best monitoring for the oxygen consumption and delivery as you can, and you can really go lower. The most problematic patients are really small patients under 50 kilograms, and also the large patients more than 120 kilograms. So you need to monitor them very accurately, but everything can be done.
I will rephrase the question because you made the easy answer. If you have GDP, everything is good. Yes, but the question is, you have GDP in both conventional and MiECC. Have you done any study that with MiECC you have lower indices rather than with conventional with the same GDP standards? If you do that, then we would say, okay, MiECC, because it's a closed circuit, have better circulation, microcirculatory effect, have much better outcomes to SIRS, to all other parameters, hemodilution, then lower indices regarding the conventional one could apply even without GDP. I mean, this is something that is significant. Have you done any of these studies?
We have done in-hospital research, of course, just to implement different techniques and follow these techniques up. And we can say that before we had spectrum devices, we didn't have any GDP monitoring at all, and all was done by a gut feeling. But the research showed that even with the gut feeling, there is no problem. And there are no difference between the patient groups in the ICU or in the recovery in the ward. So you can really go low because of the higher hemoglobin levels and other good stuff that we know that minimally invasive technique provides.
Okay, thank you. Before we go on with any questions in the second stage, there are 4 questions unanswered, and it's free for you to pick up the microphone and answer. First of all, are fast-track algorithms in ERACs enhanced with MiECC use? Do you think MiECC is mandatory in ERACs? Any of you can comment? Elena or Stan, the anesthesiologist?
Yeah, we all agree that there is evidence for a preserved organ function after MiECC surgery. So these patients are very good candidates for fast-track management. MiECC mandatory, I don't know, but sure facilitates the procedure of extubating the patient, because after MiECC we can see better preserved respiratory system, kidney function, and we can proceed with extubation earlier. I think that the only issue that we have to deal with is the effective control of postoperative pain. Otherwise, the patient is very fast after surgery on MiECC, fulfills the criteria for extubation. And there is, of course, the advance of preserved hematocrit, of the complete avoidance of hemodilution or volemia is very good for microcirculation. We have seen that. And all these factors facilitates fast-track management in these patients.
Okay, last question, because the 2 at the end are for discussion with the audience, is probably for the 3 perfusionists we have here. Is the rationale of MiECC valid without MiECC use? And if yes, or if you combined anyway, what are the difficulties when applying MiECC on MiECC? Ignacio?
Yeah, it is really difficult to respond to this question, but the answer probably is the first question is about the venting system, because, for example, in a mitral valve repair today we not have a system that give a closed suction of the endocavitary blood. In particular, many perfusionists use the hard shell venous reservoir to collect the blood from the aspirators, and I believe that is not really MiECC, this approach. Is important to assess that today the minimal invasive cardiac surgery show excellent results without an excellent extracorporeal circulation, because it is a conventional system, often optimized for retrograde autologous priming, optimized for oxygen delivery, but is not optimized for microcirculation, inflammation, prevention of hemolysis. I believe that the MiECC can improve substantially the results in the future, in my perspective, of minimal invasive cardiac surgery. It is important that the company develop a new system, a new device to improve the management of these aspects.
Well, I would now go to the audience, because there are 4 senior managers from the companies that are endorsing and sponsoring this event. It's Sevada Avaksumatian from Medtronic, is Luca Derio from Livanova, is Andreas Becker from Terumo, and it's Mike Van Driel from Life Motion. So the question before the last is, do we have to redesign components of MiECC circuits? Which will be the major recommendation to the industry for simplifying MiECC strategy? That should be our question to you then. Can you please comment on the necessity of redesigning components, or we are happy, all your customers, your physicians are good with the circuits, with the cannulas, with the bubble traps, with the pumps that we're using, the cell savers, If it is that, okay. If not, what would you do? And then the physicians here and the perfusionists will reply to you. So, Sevada, can you please comment on that? You need the microphone. Short answer, just to know if there is an input from the companies to this topic.
Good afternoon, everyone. Thank you, Professor Anastasiadis, for the question. Short answer, yes, if that's the short answer that you're looking for. But from a strategic perspective, from an industry view, every one of these efforts that you guys are doing to be able to bring benefit for the patient should be also rewarded by products that are developed specific to what you need. Now the question is how fast this is coming on the market, and the let's say the dynamic of the European market to be able to bring these products on the market is something that is a bit difficult to respond at this point of time, at least from a Medtronic standpoint. And I hope tomorrow I will be able to bring a little bit of these answers. So I'll try to keep it short. So
okay,
I'll leave
thank
space
you.
For others.
Luca Dario from.
Hello, good afternoon. I replicate basically the answer of my colleague.
Okay.
Yeah, exactly. No, it is true that there could be the need, an imagine also for you to have something specific and really helpful for approaching the MiECC. Like, for example, we were talking about venting and so on. So everything that could in some way help you in improving the perfusion in this situation. On the other hand, we have also to balance the, let's say, the strategies of the company and also the huge portfolio that we have to manage in the daily practice. So that is why we have to counterbalance. On the other hand, I mean, any kind of suggestion that comes from you that are the best user of those devices is more than welcome. So.
Okay, thank you. Andreas. It's here.
Yeah, so thank you for inviting us to comment from the industry side. I would answer the question in two ways. So first of all, I believe, yes, we have all the equipment available that is required to do MiECC circuits type 1 to type 4. So the components are there. At the same time, the major aim of the MiECC Society is to improve biocompatibility and reduce adverse events of extracorporeal circulation. And I think there we have ongoing efforts to constantly improve our equipment in terms of reducing the priming volume, increasing the biocompatibility, using coatings, increase the elimination of micro air and embolic factors, for example. So I think all the companies can show big progress in that aspect. It's more, if I can give a question back, is there anything we can do really about the general design of MiECC circuits as they stand today from type 1 to type 4? I mean, isn't that the question of acceptance in the daily clinical practice that many centers are saying, you know, there are safety concerns expressed from the Japanese markets. Also, we know in North America, there's basically no adoption of the MiECC concept. So that's, excuse me, but that's my question back to you. Is there anything we can do to fundamentally change the design?
Thank you. That will be answered by the opinion leaders later on. So Mike Van Driel.
So I'll answer your question in my presentation. That's my answer. So.
All right, that was quick. So yes, Mike will present later on about the history on MiECC development. So this is back to you then. Anyone that wants to comment on what we have discussed? What I would reply to Andreas, that he's right, that all equipment is available. Though, Andreas, most of them are designed 25 years ago. Of course, they've been refinement throughout this period, but I would say that you cannot do gourmet cuisine without having first-class products. So industry is developing to transcatheter to all these robotic VATs and very, very technological advanced components reaching to AI, and we need to be refined. Otherwise, how will we comply to this digital era without having the best? If we believe we are the state of the art, that's why we need you. That's why we need you to embrace what we are thinking, what we're researching, what we're advocating, and have this mutual feedback to go for. But is anyone to comment? Yes, of course. Ashraf.
Yes, I think the answer is quite simple. We have a nice classification. I don't need it anymore. I want to endorse type 4 systems. They give me maximum modularity. I can do every case with that system. I have a fallback, a parachute if my test plane doesn't land where I want. I open up a reservoir, I integrate a reservoir. We can discuss if we need hybrid systems like those that are propagated by Thessaloniki, or we use plug and play systems like those that were propagated by Braunschweig. But I think these two systems are the way to go for the future. There was a time for the classification, but we're beyond that. A decade later, we should all endorse type 4 systems. This would make it attractive for industry. You have to produce type 4 systems. You can improve type 4 systems, improve the components, the modularity, but keep everything else to history.
Anyone else? Any comment to this question? Yes, Brian.
Yeah, just in response to Ashraf's comments there, I think that kind of speaks to the difficulty of designing a circuit that everybody agrees on. Because if you're saying you want a type 4 circuit, well, I don't want a type 4 circuit. I want a type 3 circuit. So picking a standard and picking the components that are going to be the most liked and the most widespread, I think, is where the challenge comes in.
But then we get back into the difficulty of the classification and the nomenclature, because a type 4 system is nothing else but a type 3 system that provides you with a solution in case of need. So if you don't want to have it integrated in the system as a hybrid, you have a plug and play. You can insert a reservoir into the system when you need it. Yes, you will need 30 seconds of circulatory arrest, but 30 seconds of circulatory arrest coming from a DO2 that is way beyond what we need shouldn't be the problem. So yes, you get your type 3 system. I'm gonna use your type 3 system. But the only difference is if I need a reservoir, I can integrate a reservoir.
So just order a bunch of cardio helps and then cut in a reservoir.
There's more to it.
Yes, Ignacio. Yes.
There is another important aspect that I believe that is really interesting. We talk about the product, we talk about the biomedical company, but I think that when a perfusionist starts with MiECC, change your philosophy and practice in conventional context. It's important to say together that when perfusionists improve the practice with the philosophy and the methods of MiECC, export this vision in the conventional approach. And it's really important that the philosophy and the methods becomes more important than the products. The products support the methodology. We talk about type 4, we talk about type 3, but I believe that the perfusionists that start with MiECC do a conventional cardiopulmonary bypass with the aspects similar to management of MiECC. For example, reduce the length of the circuit, reduce the pump head, reduce the priming, reduce the drug administration. I believe that MiECC is the solution to improve our conventional approach in the impossible MiECC surgery. What do you think about?
I would totally approve what you said. MiECC, you do practice MiECC or you don't. It's a qualitative variable. It's yes or no. And optimized extracorporeal circulation is a continuous variable. You can start from the conventional CPB up to something which is quite similar to MiECC. And finally, in respect of physiology, the philosophy is the same. And then you obtain finally the same results, I think. And one of the issues to explain the low penetration of this technology, type 3, type 4, is probably due to the fact that having such a system, which is sometimes difficult for some group to be used, may be scary. And finally, I think that we have to promote also the philosophy of the system more than the system by itself, if you want to convince the different groups and the cardiac surgeons and all the groups of anesthesiologists and perfusionists to do on this direction for the better outcome of their patients.
Okay, and now it's time for the audience. Do you have any question? Is there any question from the floor that it can be answered? Yes.
Yes, Dr. Perez.
Dr. Perez from Athens.
You will get it in a
The
minute.
microphone. You will get it.
Thank you for the invitation on this great meeting and congratulations for many years of hard work. It shows that you have advanced a lot. I'm actually very interested in this also in the sense that we're developing mixed surgery over the last few years in Onassis. And I'm a very passionate believer of mix, but not of mix that relate just to a smaller wound. And you have alluded to that today, many of the very esteemed speakers. So we really need to minimize what we're doing and to improve this. In fact, we need to make it safer for the patients, whatever that means. So as a general approach, I have been convinced of the literature in many aspects of MiECC. I do believe, though, that yes, we need to be flexible, as the colleague said, because there are a lot of things we don't know. We really do not know, for example, as you very well know, and that applies to the ECMO and so on, whether a small pulsatile flow may change the response of the end organs. The end organs are not just DO2 and lactate, even worse, as you professor has mentioned before, lactate is too late. When you see a patient in surgery and the lactate has started building up, it means something has been going wrong in the end organ oxygen uptake a long time ago, quite a few minutes. Maybe you're late chasing and you hope that your perfusionist is early enough. So the question is, do you think that there is space to maneuver not just on the basic circuit, which I'm sure it's developed more and more, and I understand the main problem, which is that we need to have some kind of suction. I do a lot of mitral surgery, and I quite agree with you. This is very appealing because we want minimal surgery. And in fact, if we want to keep the surgical practice, this is the great victory of the cardiology community and the surgical community in the non-invasive approaches. It's not just the smaller wound, it's the lack of bypass. So in theory, we want to develop a bypass system that is not really a technology-based thing. Of course, technology is going to help you in this. So the question is, do you think that there is lack of evidence and a great field to actually investigate exactly what is that makes the end organs damage? So what I'm trying to say is MiECC has a benefit, but you will still agree if you take too long on surgery, again, you end up with similar problems like on a standard bypass. So are there other details, not just related to the miniaturized circuit, which is very important, but other things too, like the membranes and so on? So sorry, it's a general question, but I'm very eager to see where technology can get us, because I think then when MiECC increases the efficacy and the margin, as you say, for example, in an easy case, this is very important. We do very well in easy cases, but if really this advances more, then we will see the results even in very simple, easy cases, and then MiECC will be all over the place.
Any answer from the participants? Maybe Ashraf, or you want me to answer? I think Ashraf can answer. Or Elena. Yeah. No, Ashraf, you can go.
I think it is a very valid point, but it is beyond the scope of our knowledge at the moment. However, the point is we have enough evidence to support that even in easy cases, MiECC has an advantage because you definitely have one thing that most of us can agree upon, you have a difference in the incidence of postoperative atrial fibrillation. And this is a significant issue. Maybe we're not giving it enough weight, but it is definitely a significant issue. If we were cardiologists, we would have built that issue up to the Everest. But we definitely have an issue about patient blood management. We definitely have less transfusions. The problem is we cannot adapt MiECC and say expect less transfusions if we're following a liberal transfusion policy. The machine cannot be so good on its own, or the philosophy is so good on its own, that I'm using a liberal transfusion policy and then I'm expecting that I'm getting less transfusions. So it all has to go hand in hand.
If it was our choice, we would definitely choose MiECC systems 100% in all cases. But surgeons, you are the gatekeeper, so you choose the type of circuit.
Just I will go back to Helena to finalize this reply. She said during her talk in the morning that microcirculation is the key point on this. And we've done extensive studies on this, and you can see that microcirculation is very better preserved when you are using MiECC. So that's the key point. And then you can build it up with all the rest. So sufficient evidence is there. We know the rationale, but you are right. There are a lot to be done so as to convince the community, but there is sufficient evidence. So just to finalize, I will go the other way around here, a last speech, but try to take on your speech the last question. This is provocative. Which is the main issue for not adopting MiECC in its discipline, your discipline, and which could be the actions respectively for making MiECC use more appealing? As Kostas Piraeus said before, what should we do? Is it the companies? It is us? Is it, I don't know, the healthcare system? Who will be responsible for advancing it furthermore? So let's start from that way here. And Sten, it's your turn.
Well, this is a very complex issue, and to implement new techniques is always a challenging. So in a way, you need some kind of pioneering spirit to drive the new things into your system. And if your current practices deliver decent or even good results, you are not so keen to change them. And this is, in my opinion, is one of the key things. So we must have a pioneering spirit.
Okay, thank you. Helena.
I think the team is necessary. We have all to be believers, so anesthesiologists, surgeons, and perfusionists in order to start a program. And as I said before, unfortunately, we don't choose the type of circuit. Otherwise, we would go 100% for minimal invasive. For us, it has only benefits.
Thank you. Now, Yuki.
Yes, I'm a surgeon, and so I think evaluation and the scientific value, we should show the scientific value of the MiECC to the surgeon and the perfusionist. This is one of the most important things.
Thank you. Ashraf?
I think this is a very complex question. We've been trying to answer this one for the last decade. We definitely have a communication and marketing problem. I think that we're not getting the message out there enough because there is enough evidence. We used to say there is not enough evidence, but there is enough evidence. And we, as surgeons, we are very conservative. We are very concerned about complications, and we're often driven by the improvements of cardiologists in order to change our practice. But sometimes we are so latent in our reaction that we might even lose something. I don't know if in 10 years we'll be doing any aortic valve replacements anymore. And this is a serious issue.
because I'm certain that the valve that we're implanting is better than any TAVI. But now with the cardiologists are even speaking about life planning of aortic valve treatment. So implant a TAVI at a young age so that you can implant a biological valve later, so that you can implant a TAVI later on.
Thank you. Brian.
From a perfusion perspective, MiECC, I think, is often perceived as being harder to run, more difficult to run. So from my perfusion colleagues who are kind of nervous to do it, I'd say that's their biggest hesitation. But I think that can be overcome with good training and good team support. And we've seen actually, I mean, Lauren can speak to this as well. We've seen more and more uptake within our team and interest to do it. People want to do it. The biggest barrier for us actually is getting more surgeons on board to try it. And this is a question, I guess, for the surgeons on the panel. What would you say to your colleagues to get them to try it? Because when I've approached surgeons and they hear that, you know, the heart might be a little bit full still, you might have some residual coronary flow, they speak to the surgeon who does it, and Dr. Rao is very good. He will compensate and compromise by changing the position very slightly when he's doing a distal. And I don't think all surgeons are willing to compromise like that. So what would you say to a cardiac surgeon who's hesitating?
Okay. Professor Baufreton will later on reply, but let's, Christoph, let's Hans-Jörg make his talk, and then you will reply.
For me, the problem is a bit more profound. I think if you look how the characteristics about surgeons and also perfusionists, so we are not so innovative. If you look, for example, new heart-lung machines on the market, there are a lot of perfusionists that will buy the old S5. They will not willing to go into new technology. We do not believe in new technology. That's why I will have an example for a PaO2 measurement. They will not trust. They have, I don't know, have not a percentage in my head, but I think 30% of the perfusionists they will see the inline because they will check the color. They will not trust a sensor. And so if we are not change our thinking, we will never develop a perfect system, because systems, as Ignacio used them for a mix, for example, they became really complicated, and they will not solve the problem if you come out with complex systems. And if we do not accept that, we cannot always say the surgeon is guilty. We also have to change our mind as perfusionists and take the step forward in new technologies.
Okay, Christoph, now you can also comment and give your last thought.
To answer to you, Brian, I would say that, to my opinion, the main issue of this problem is the commitment of the surgeons. And you see, I discussed recently with some of my neighbors in another city not very far from mine. And the anesthesiologist told me, how would you convince your colleagues to do the same as you do? I said, okay, everybody knows the evidence. I mean, in each group, there is at least one doctor, one perfusionist, that know the evidence. But if the surgeons has no commitment with that technique, because we are conservative, as you said. So some surgeons are reluctant to use a cell saver rather than a cardiotomy suction, for instance. And you can see that in every surgical meeting on a live case with a cardiotomy suction inside the pericardial, inside the pleural cavity for a while. So surgeon commitment is a real issue for that, to my opinion.
Thank you. Ignacio.
I think that the first limitation is the training today. For example, this morning it was a success, the hands-on training lab. The creation of training with the simulator, I think that improved the penetration of MiECC in the scientific community. We start as a joke, this approach, but I think that I believe in this approach. For example, in Italy, we start with the perfusion lab for MiECC. Comes 3 person for each center, anesthesiologist, perfusionist, and cardiac surgeon, and we start with the simulation. I think that the penetration is really important to start with the training through the solution with the biomedical company. And the other limitation is that the surgeon becomes a little bit a perfusionist, because the management of the line in the MiECC is more efficiently such as perfusionist. That is the two limitation: the training and change the flexibility of cardiosurgeon in the use of this technology.
Okay, thank you. I hope we opened rather than closed the topics, so we have discussion later on, because this is a huge, huge issue, and we keep discussing and we keep have questions that have been raised. So, Polychronis, can you close?
After all, I would like to close the discussion and open the forum for the next very, very interesting lecture on point of care bleeding management. Thank you very much. Thank you very much.